So I am pleased to introduce our next speaker, Tim Wideman. He's a physical therapist and an associate professor at McGill University. To add some flair, I'm going to share that he lives in Montreal, but I thought I'd add more. I didn't know this about Montreal. It's an island, and the North American capital for tango. It's from McGill. I got it from Student Services. So anyway, please welcome Tim Wideman.
Yeah, that's right, yeah. There will be no tangoing this talk. My apologies. Thank you for that introduction. I learn about the island of Montreal more and more every day. It's a real pleasure to be here. Thank you so much. It's great to see everybody. So when we think about pain and we hear about how pain is addressed in the media, often we think about kind of big societal problems. So we think about the opioid epidemic, we think about severe isolation, depression, and in the most extreme cases, maybe suicide. And there's a really good reason for this. When pain is at its worst, it can really take everything from us. But then when we try to connect those big problems and challenges to the actual person who's in front of us in clinic, it's not always easy to do so. I think part of the reason why we have this challenge is that sometimes it feels like the ideas and tools that we have in terms of clinical management feel a little bit small in relation to those big challenges related to pain. So here's an image from a paper actually that I presented the last time I spoke at this Congress on an online version, and it was published a couple of years back. And basically it tries to get at some of these ideas. And so first, it tries to show what we can't see as a clinician or a researcher, and that's the pain experience itself. And I think it's important to appreciate what we can't see that people are feeling. And so what we're left with is basically observations and tools that we can use to infer that experience. And often in the case of our clinical approaches of pain management, these are kind of quantified assessment tools. So things like numeric rating scales, 0 to 10 scales of pain intensity. Maybe we give questionnaires that might look at fear of movement or our tendency to have catastrophic thoughts related to pain. Or maybe we have different indices that we might use to get at pain sensitivity, for instance. But even when we have a pretty comprehensive approach to assessment, we still might have a lot of uncertainty. We still might miss some of these important pieces of that person that's in front of us and what is their experience in terms of living with pain. And so this kind of maps on to a lot of literature that suggests that a lot of our patients are feeling overlooked, misunderstood, and invalidated when they're seeing clinicians about their pain. And so really what I want to talk about today is a kind of broad construct that I've been doing some research on, and I'm really excited to talk to you about. So I want to talk about pain-related suffering. First, really kind of how we've been thinking about it, why I think it matters, and then also some kind of early thoughts on how it might shape some of our clinical practice. So you're seeing me here in front of you, but I really want to emphasize a very kind of collaborative work that we've been doing. So it's very much a team approach. And I just want to highlight a couple folks that are actually in the room today. So first is Peter Stillwell. If you don't know, you should be cheering. If you don't know Peter, he's a really... I'm happy about that. Peter is a really wonderful individual, and I'm sure everybody who's clapping knows that. So Peter and I have been working on these ideas. Actually, from early in the pandemic, we'd have kind of half-day phone calls about these ideas, which were really a delight for me, and it's really been wonderful working with him on this. Also, we have Keith Meldrum, who kind of came in early onto this work and has provided kind of tremendous insights to an individual who's living with pain and really kind of contributed importantly to this. And then here we have Virginia McIntyre as well, who's here. Also very deserving of those cheers. And I just want to emphasize how important Virginia and Keith's input is on this work, and certainly wouldn't be able to be here today to present this without them. So suffering, certainly to be clear, is really not a new idea. So this is an image from John Loser's kind of classic onion model of pain, and we see suffering right there as kind of one of those core ideas related to pain. And then if we go to PubMed, type in pain, suffering, we get more than 1 million publications. So not a new idea. But one thing that we kind of argue in this paper is that it's not always really clear what we mean when we use the word suffering. So there's a lot of ambiguity, and if you look at a lot of those publications, that maybe not kind of anchored to a conceptual idea or definition. Similarly, when we look at ISP, we look at the taxonomy, so a lot of different terms, definitions related to pain, but when we look for the word suffering, there's nothing there in relation to suffering. So again, just a little bit of that ambiguity. So really what we were trying to do with this paper is trying to synthesize some of the work that's both in the pain literature and outside of it, and try to bring it together to create some kind of evidence-based principles of what suffering is, but also highlighting pieces that we don't know yet, and kind of thinking about how it might shape clinical practice in some early thoughts. So this here is the kind of most technical image from this paper, so you can just take a moment to let it sink in. So yeah, when we were trying to publish this article, reviewers are like, no way, this is not going to fly. But we had to really kind of, we searched, there was not this image kind of presented before, and we were able to make the point that hey, this is a pretty foundational idea, that pain is not the same as suffering. And this is important because when you look at a lot of those papers that I referenced before, they'll kind of just use, person suffering with pain, and it's just kind of thrown out there in a lot. And a lot of when we think about, how we anchor our practice and our research, often is towards the alleviation of suffering. But again, that kind of makes the assumption that everybody who's living with pain is suffering. And so what's important to recognize is that completely possible to have pain and not suffer because of that. So that could be a minor pain that isn't disruptive in a major way to you. Similarly, it's important to recognize that you can suffer, and that doesn't have anything to do with pain. So I might have lost a loved one, I might be experiencing isolation, depression, different things that might be separate from an experience of pain, or for somebody who's not even having a pain experience. But what we're interested in today is looking at this overlap between those two contracts, so pain-related suffering. And that's really kind of any suffering experience that can be associated with pain, kind of directly or indirectly. So let's talk about this a little bit. Let's talk about that overlap. So let's talk about what's similar between pain and suffering. So first, we define both of them as a subjective experience. And I really love actually how Lozer framed this in a little bit of a quote on suffering. So there are no physical examination clues or laboratory tests or imaging studies that reveal its presence. We must ask the patient and listen to his or her narrative to find suffering. One cannot assess suffering in a patient whom one does not know. I really like that quote. I think it captures that idea of subjectivity really well. Another overlapping piece is we think about negative affect as being a common piece of pain and then also suffering. It's not hard to imagine. Suffering for most people is unpleasant by definition. But if we look for distinct aspects, what we framed in the paper is this idea of disruption to oneself. And what I want to do in the next little bit of this talk is kind of unpack what we mean by those ideas. And so, I mentioned there's a lot of ambiguity around suffering, but there is a little bit of theory that a lot of this work, when they're using the term purposefully, is anchored to. So when we look at Lozer's work, what he's referencing when he uses the word suffering is work that Eric Cassell has done. So Eric Cassell was a physician, an ethicist, and really was an early pioneer in trying to prioritize the person, the patient as a person, and trying to prioritize thinking about the patient as a person. And so when Cassell was thinking about suffering, he really influenced the field by publishing a seminal paper in the early 80s in a prestigious journal. And if you look at those publications I referenced before, you can kind of delineate before and after Cassell's work when we started to use this term more, and when that started to shape clinical practice as well. So if we get into Cassell's, how he thought about suffering, there's maybe some ambiguity in terms of how he addressed it. He didn't really, I think on purpose, didn't want to pin down one definition of suffering. But this is a text that I think kind of gets at that a little bit. So quoted from one of his papers, most generally, suffering can be defined as a state of severe distress associated with events that threaten the intactness of the person. And so part of what we were doing with this paper is trying to look at Cassell's work and think about some of the critiques, because there's been a lot of important critiques of his work, and try to integrate those, synthesize those, and maybe revise some of the contributions that he's made. And so the first was just looking at the language that he used. And so again, if you kind of think about some of this language, severe distress, distress is a kind of a general word that we thought negative affect would be helpful to get at. The person, we wanted to use the word self, in part because there's just been a ton of research that's looked at self-experience, selfhood, since Cassell first published this work in the 80s, and we thought that would be a helpful way of getting at some of the experiences, and I'll unpack that a little bit more in a moment. And then instead of threaten the intactness of the person, we want to talk about disruption in relation to one's sense of self. So it's a little bit in terms of how we got to that language. So all of this is broadly consistent with what Cassell was getting at, we think, but a little bit of a revision in terms of language. But also what we did in this paper is we tried to create a place where we could maybe revise some of the ideas that Cassell was using to kind of get at pain. And so importantly, Cassell really framed suffering in one specific way. And I'll talk a little bit about that in a moment. And what we're proposing in this paper is to try and create some space to think about suffering in more than one way. And specifically, we're kind of proposing two modes of suffering. And those two modes, I'll talk about them a little bit later, but again, it's anchored to this literature on self-experience. So a lot of it's influenced by Sean Gallagher, who started publishing on this idea in the early 2000s. So the first piece I want to talk about is narrative self. And so this is one of those self-experiences, and more or less, it basically maps on to Cassell's person. So when you think about personhood, selfhood, narrative self, these are all kind of related terms that map onto the same idea. So when we're thinking about defining narrative self, a collection of words we could talk about is more or less coherent self-image that is constituted with a past and a future in the various stories that we and others tell about ourselves. So if we unpack that a little bit, we could think about self-identity as an important part of the narrative self. And what's important to also point out is that narrative self, when we think about it, is inherently self-reflective. It's inherently autobiographical. It's thinking about ourself in a sense of time, past and future. The other thing that maybe can trip some folks up is when we think about self, we often think about the individual, and we sometimes have a tendency to think about the individual in some sort of void, like they could be separated from the environment or the social context. And that, just to be clear, that's not at all how we're thinking about the self here. The literature that this is based on is really kind of thinking about the self in an activist kind of context, situated in the environment and that context, and inherently social. And the other thing is sometimes when self can trip folks up, particularly if you're thinking about this from an Eastern, maybe Buddhist perspective. And so sometimes you could use a word, what gives an individual unity and purpose instead of maybe using that word self. So all of those ideas are kind of getting at this construct of narrative self, which is by design intended to be very broad and inclusive. So let's talk a little bit about how pain can disrupt the self. Let's use a very old picture of myself. And actually, I was going to unpack, how we could think about, different aspects of my identity and kind of think about how pain could disrupt that. But I meant to talk to Joletta before doing this. But as Joletta was talking this morning, I was just jotting a couple things down. And I think the talk that she gave this morning and also yesterday for folks that were there was really kind of evocative of how pain can disrupt that narrative self or identity. So things like I couldn't do the things that made me feel like me. I was no longer myself. I didn't like myself anymore. So these are all getting at that idea of how pain can have this disruptive role in relation to that narrative self. So if we think about these attributes of pain, we have this partial overlap with pain and suffering. Attributes of suffering. We have defined as a subjective experience characterized by negative affective valence, and then we have disruption to one's sense of self in one way that involves narrative self-disruption. There's a fair amount of literature that kind of gets at this. So what we've started to do, and this is just kind of preliminary work, we've started to do some research that gets at, in a little bit more granularity, exactly how we can kind of think about narrative self-disruption. So there is a lot of work. Fran Toy's work was highlighted before. I think a lot of that work points to the idea of narrative self-disruption. So we started to do some interviews, and just one thing I just want to mention about kind of partnered approaches to research. It has been such a lovely and enriching experience to partner with folks who are living with pain. As we're planning these interviews, as we first do these interviews, we can pilot them, get feedback on them, and the whole approach. And I think that it's really kind of been these partnerships with, in this case, Keith and Virginia, that has made this work really possible. The other thing I'll mention is I'm doing these interviews, and I don't have a rich background in qualitative work, but it's been a really wonderful experience for me to kind of get a better understanding of what it means for individuals to live with pain. So this particular interview on narrative self, what we focused on is really trying to ask people who are living with pain to describe their life almost as a story. And then we kind of bring in pain. We say, hey, how did pain fit into the story? And what we're looking at here is understanding the potentially disruptive role that pain has played in the story. And then what we want to do is that we want to unpack what that's meant for different kind of life roles, values, and their sense of self. So what I want to share is just a couple quotes from some of our pilot work on this. We'll talk about some themes, and then we'll kind of go on to think about other forms of suffering as well. So this is a younger individual who is talking about their pain. So I was in a school program, and I was just so passionate about it. I would say I lost all of that. I felt like I lost my identity as someone who is emerging in that field of study. So there's a pause here, and there's some emotion. And she says, it's funny because talking about my loss of roles is actually more painful than talking about my pain. It's almost like that loss of identity is just so painful to think about. Like even now, and this has been years later, it still kind of hurts. Another individual who spent a life working in the military and describes it this way. I didn't see it being a life worth living. So it was at that time that I took my gun and I was going to end it. It wasn't just one specific incident in my life that decided that was that. It was pain, suffering, shame, loss of my manliness, loss of my sexuality, loss of my bodily functions. It just seemed endless loss, and that there was nothing left to be gained. I no longer had a purpose moving forward. I just want to emphasize, how often we didn't have prompts specific around suicide, but in this interview and the other ones I'll mention, just how often those concepts came up. And so here we see clear examples of loss of profession, loss of gender, sexuality, purpose, and contributing to an overarching sense of despair as well. I think what's interesting about talking about narrative self and some of the ideas that we're getting at in these interviews is we start to see a trajectory, and we start to see how pain can really kind of shape that trajectory of somebody's life. And we can kind of see how there's life before pain and life after pain. And unfortunately, with a lot of folks, particularly those that are coming to see us for treatment, that's not a positive thing for them. There's a massively disruptive role that pain has played in their life. I'm really interested in work that's done by Dan McAdams. He looks at, he uses the word narrative identity, but really gets at similar ideas related to narrative self. And he presents this hierarchy of thinking about personality. So he has this wonderful paper that talks about what we know when we know a person. And he says, okay, well, we can talk about traits, big 5 factors, neuroticism, optimism, introvert, extrovert. And then we can talk about different coping strategies that individuals might use. But when we use those aren't quite enough to describe the person in front of us. And so he presents this idea of narrative identity or narrative self as basically a higher order kind of construct in terms of important piece of what makes us us. And I think in the pain research world, particularly when we're thinking about what interfaces with clinical practice, there's sometimes this is a missing piece in what we're looking at. So I've done a lot of work in the past on the fear avoidance model of pain. And so thinking about fear avoidance behaviors or our tendency to have catastrophic thoughts, those can be kind of anchored in that coping strategies, but it doesn't let us get at that narrative self, that piece of identity that is so important to living with pain. Okay, so we're talking about these different self-experiences. We talk about narrative self, and that's really kind of anchored in Cassell's work and talking about personhood. And there's kind of clear relationships with pain in the literature, and we kind of summarize some of that work in our recent review paper. But then when we think about our life experience, we think about everybody in this room kind of navigating a typical day. The narrative self only captures a piece of that. And so you think about yourself autobiographically, the past, the present, my identity, but that's probably not your full experience. You also have this kind of stream of consciousness that is moment to moment shaping your experience of the day. So to get at this, we could think about a meditative experience. So think about when you're trying to meditate, what you're actually cultivating in that experience. You're probably letting parts of your identity, your thoughts about that, fade away. You're probably trying to let the sense of the past or projected future shape away. And you're probably trying to cultivate a bit of an awareness around your body in the present moment. Or we could think about an infant. And we could think about the type of consciousness that an infant has. And there's some really cool work that shows that, in very rudimentary but important ways, infants have this sense of their body. They can differentiate what is their body from something else, and they have this rudimentary sense of agency over that body as well. And so there's been some really great work, in part led by Sean Gallagher, that's kind of given a name and space to this type of self-experience as well. So it's named the minimal self-experience, and that's kind of capturing these ideas. And so to be clear, everybody in this room, my expectation is that part of your life experience, part of your moment-to-moment experience is shaped by both this minimal self-experience, which I'll talk about in a moment, and also that narrative self-experience. It's part of what makes us adults and be able to kind of navigate our worlds. So the minimal self-experience, the way that we define this is that kind of in-the-moment stream of consciousness, here and now experience. And importantly, we use the word pre-reflective. So it's not this idea of thinking back into the future, thinking about yourself in some sort of objective third-person way, thinking into the future or past, but it's an immediate sense of consciousness. And what's important here is that, this seems like a bit of a mean image, Cassell really didn't have a place for this way of thinking about suffering. And he was really explicit about this. He was explicit that infants, non-human animals, don't experience suffering, and they don't do that because they don't have a sense of identity. But for us, as we kind of had these early conversations about it, it seemed like there's an important missing piece there in relation to pain. And so we were kind of thinking that pain would have this important disruptive value in relation to that minimal self-experience, and that should be recognized as another way of suffering. That was a bit of our hypothesis as we started doing the interviews that I'll talk about in a moment. So this is another set of interviews that we've done. We've kind of finished data collection, finished analysis. We're just trying to get ready to share these in a form of a publication. But basically in this context, we did these long-form interviews. We took a different approach. The last one was a bit more narrative. This one was anchored in phenomenology. And really the idea was to try to understand in a really in-depth way what it was like for somebody who's living with chronic pain to experience their worst pain experience. And so what we did in these interviews, we kind of revisited the moment-to-moment experiences of that worst pain in terms of what they felt in their body. What were their thoughts? What were their feelings? What was their relationship to time? What was their relationship to space and other individuals? And kind of incredibly for me, like we could not find any work that found this kind of used this kind of methodology that was looking at these kind of questions in the literature. And what we found out early on, just doing our pilot interviews, is just how intense these conversations were, and how potentially triggering they would be, and how much precaution we needed to take in doing that. So we kind of had our IRB all sorted out, and then we realized quickly we needed to develop a safety protocol and figure out how to be responsible in having these conversations. And I feel like we did a good job with that. So what I want to talk about is basically some of our findings, and I want to anchor it to different aspects of minimal self-disruption. So there's different ways that we can think about minimal self-disruption in relation to ownership of our body, agency, and so I'm going to talk about that in another little aspect that we found in our work. So I'll read some quotes, and then I'll talk about those themes and how they relate to each other. So first, related to loss of agency. It's like a form of dementia. It's hard to think clearly. You can't. It's like the pain overrides common sense. It overrides everything. It's almost like your brain shuts down and you're just in the pain, and the pain is consuming you. I'm just this ball of pain. I'm not even a person. I don't think it was possible to do any type of reflection. I was just having to deal with the here and now. Rather than being able to think through it or to think anything, it was just me and my pain. It really just felt like I was this giant existence of pain. I couldn't even access any part of my brain that was a thinking based. All I could focus on was pain. I just went backward, like I went back into the embryo. And so what we saw was really kind of all of the individuals that we interviewed mapped on to this idea of loss of agency. And it pointed towards a sense of being overwhelmed, incapacitated, but also dehumanized. And I think part of that dehumanization is that, when you hear these quotes, that there's a complete separation from that sense of identity. So it's almost like you're not able to access those pieces of yourself that are yourself in a way. I'm not able to access the idea that maybe I have kids, maybe there's people that love me in the world. Then we also saw this idea of disrupted sense of bodily ownership and awareness. So again, I'll read through some quotes and then point to some of these sub-themes in them. I felt a little like not in my body, like I was dissociating because of the pain. It was very bizarre. It felt very strange, like I wasn't present in my body. I was looking at it from up high. I think I felt out of body when it started to get to a point where I didn't know how I was going to get to the next minute. So it's like I came out of my body so that I didn't have to get to the next minute, but it wasn't me. I didn't feel like I owned my body, like my body was not mine. I think that was one of the hardest parts, actually. Like I was a complete loss of my body, my autonomy, and my independence. And so what we see here is that sense of dissociatedness, disembodied, and then a strong need to escape from those experiences. And this for me was in some ways just really shocking to see. I don't think I'd realized the extent to which the pain had the capacity to do this. The other piece that we saw is a disrupted sense of time. And this was actually captured by pretty much all individuals when they were talking about these worst pain experience. So I'll read a couple of these. There was no sense of time. I couldn't have told you what day of the week it was. I couldn't tell you what time of day it was. I couldn't tell you whether it was night or day. It's sort of like slow motion, and time goes much slower. The pain is controlling you, and it seems it's never ending. It's like a minute is an hour. I had no sense of any time. I felt like I was frozen in space. And so the idea that time is kind of slowed, frozen, or just kind of a lost sense of time. And so when you put these ideas together, and you ask yourself, what is it like to have these kind of minimal self-experiences? And again, I want to be clear that we're talking to individuals often who've been living with pain for long periods of time, and they were really talking about their worst pain experiences. And I'll try to situate this into more day-to-day experiences as well. But when we're talking about those worst pain experiences in a study that we've done, what we're seeing is this laundry list of really kind of, in my mind, extreme kind of descriptions of feeling overwhelmed, incapacitated, dehumanized, disconnected from self-identity, dissociated, disembodied, need to escape, frozen in time. And when we look at this list, so clearly for us, and that'll be the emphasis in this paper that's coming out, is this is another way to suffer with pain. And I think it's a way that hasn't been adequately addressed in our pain research. I think we get at pieces of executive function, dysfunction, maybe a little bit of emotional regulation. But for thinking about primary care management, I don't think these ideas have really found their way into practice and shaping practice. But from our point of view, we really think this is an important way of suffering that needs to be understood, validated, and also intervened upon. When we're looking at the literature and we're trying to find experiences that map onto this, kind of sadly, the main work that we could find were first-person descriptions of torture. And they're using kind of similar words and sadly, when you think about the kind of purpose and what's trying to be done in physical torture, there's trying to separate yourself from any kind of cues that would give you a sense of place or time, or any kind of cues about what make you you. And the focus is trying to be on that physical discomfort. And what we're hearing from individuals who are living with pain is there's a meaningful connection with those types of experiences. Okay. I'm gonna get some water. So we have two different interrelated modes of suffering. This is what we're kind of proposing. So the one mode is narrative self-disruption. So we talked about that earlier. That's that sense, that reflective sense of yourself, your identity, and how pain can disrupt that. Then we have this other piece where there's a lot less literature on it, but we have some really interesting findings that for us kind of situate pain as an important contributor to minimal self-disruption. And what I want to talk about in the next little bit is really kind of how these two things are interconnected and how we should probably be looking at these things as having very close relationships with one another. So the first thing I want to talk about is what we noticed in our interviews is there were a lot of folks that were commenting on the fluidity between these different modes of suffering. So I want to read to you one quote that I think captured this idea really, really well. So my pain would go down and the thoughts would come up. There was a direct relationship between the two. Like my pain would go down, say, 10%. I would add in thinking about school. My pain would go down 10%, add in thinking about the fact that I'll never be the same sister. Go down 10%, oh wait, I'm gonna let my parents down. So it was like, as I was getting control of my pain, all the thoughts came in. And I think that's maybe why I keep describing it as a wave. And I really love this metaphor of a wave. And when we're thinking about these different modes of disruption, we can kind of think about, how these waves of intense pain wash over us. And what we're finding that's happening there is you can think about, our capacity, our bandwidth for self-reflection. And as the pain intensifies, we go past that capacity for self-reflection. That's when you have that minimal self-disruption, where there's that loss of agency, maybe even in extreme cases, that feeling dissociated, disconnected from your body, frozen in time. But then as the pain subsides, you think, oh, great, that's a good thing. But then you have these waves of narrative self-disruption that can roll in. And you're kind of situating that pain that's kind of just, you've lost your mind in the pain in a little way, but you're situating that in terms of other forms of disruption. That's what's being described here in this kind of fluidity between the two. So as we were kind of working with these ideas relatively early on, in conversations with Keith initially, and then with Virginia and the rest of the team later, we talked about this idea of a messy middle. So we've been talking about these kind of disruptive forms of suffering in kind of extreme ways. But I think what's really important to recognize is that these are also relevant in the more kind of mundane day-to-day experiences of life. And so Keith kind of coined this idea of messy middle, and I just want to use a little example to kind of get at that. So you can imagine an individual, let's say, who's married, and they have a role in the household to kind of look after, house maintenance and things like that. And so there's a little project that's involving, seems really routine, goes up a ladder, tries to work on this little project, but in the course of doing that is kind of really surprised and maybe to some degree overwhelmed by having a strong kind of pain flare-up. And so having this pain flare-up, there's kind of this like, okay, I need to take a moment, can't talk to anybody right now, I need to lay down, maybe need to write off the rest of my day for a little bit. But as that starts to subside, then those thoughts related, come back, and it's like, geez, this happened in such a small activity, it's such a meaningless little activity, but if I can't do that, then what does it mean to be in this relationship, to be a partner, to have this kind of household responsibility of looking after this kind of maintenance. And so this would be an experience that wouldn't have sought any healthcare related to it, but in a day-to-day way would have, you see these aspects of minimal self-disruption and narrative self-disruption, and they kind of relate back and forth to one another in that fluidity and interrelatedness. And so when we think about pain-related suffering, I think it's important to think about those two things in combination. So we have that in-the-moment disruptive value of the experience of pain, but then we also have that life story, that bigger narrative piece disruption as well. And there's an intermingling of those two things, and right now that's kind of how we're thinking about pain-related suffering. So when you think about that construct, and we're trying to think about, so what? we're kind of maybe figuring out some new things about what it means to live with pain, but what does that actually bring to the literature? What does that bring to clinical practice? And I think first, it's important to recognize that what we're assuming, we haven't looked at this in any kind of explicit way, but what we're assuming is that there's really important overlap between these types of disruption and the psychological constructs that we already know and use in the literature. So I want to just point that out. But I think that where I see the added value of this construct is that arguably it might be a little bit broader, a little bit more comprehensive than maybe some of the work that we've done in the past in this area. So coming back to the idea of the McAdams kind of hierarchy, most of the work that we focused on is in this kind of coping-like behavior. So fear avoidance, behavior, how we're thinking about pain. But part of the appeal for me in thinking about narrative self-disruption, it gives us access to go a little bit higher than that and thinking about, again, that life trajectory, again, themes around identity and how those might be important for our patients. But then the other piece is it also goes somehow lower than that as well. So thinking about more basic cognitive function, more basic aspects of consciousness that it can completely rob us from in those moment-to-moment experiences of minimal self-disruption. And so I think the appeal for me is thinking about a broad heuristic that could have important value in getting at a little bit more of the wholeness of that person in front of us who's living with pain, particularly I think in a primary care setting. So I want to finish by talking about really what are some preliminary thoughts, and I want to emphasize that, on assessment and management of pain-related suffering. So we've not done research on this. This is really kind of best guesses from this vantage point based on me and our team a little bit. So I think what's really important is trying to think foundationally about management and really how important it is to think about trying to understand suffering from the point of view of the person who's living with pain, trying to recognize and validate that suffering experience. And I think Joe and Mel did such a great job of doing that yesterday in terms of giving us really good strategies and tools to get at that. When we're thinking about assessment, I think that coming back to these ideas about our tools that we're using, the other part of this image is basically this kind of sphere. and what we're trying to get at there is basically, one, the pain narratives, how people talk about their pain, and then also any kind of observations that we could make. And I think there's a lot of richness in this content, and that's partly why in this figure it's designed to be bigger and broader than these kind of more narrow cones of pain measurement around it. And so I think when we're talking about suffering, I think that there's extra value in taking time to listen, carefully observe, more so than precise measurement, at least in kind of the initial stages. So if we go further with this and we think about different approaches to assessment, I think what's important to think about is these different modes of assessment and how that can shape assessment, but then also, these different modes of suffering, how that can shape assessment and also management. So let's think about trying to assess narrative self-disruption. I think using open-ended questions that get at ideas of identity, life impact. So things like, can you tell me about some of the most important ways that pain has disrupted your life? How has pain stopped you from being who you want to be? So these could be good questions as starting points. And then from there, really trying to listen, trying to unpack what the person in front of you is trying to tell you. Now, when we think about minimal self-disruption, I think we could start in that kind of conversational approach. So we could use questions like, can you tell me about moments when you've been feeling particularly overwhelmed by your pain? And then maybe what we want to do there is try to understand, what does that feel like for you? And what we're trying to get at is how disruptive are those pain flares for you? How often do they happen? What is the net impact on what's most important for you? The thing to remember, though, here is that if the patient that you're seeing is in a moment where there's a lot of that minimum self-disruption, so maybe you're in an ER, maybe they've just had a flare-up, and they're kind of like dysregulated, dissociated, they're not going to be able to talk about these things. And so the idea that that capacity for self-reflection, discussion, that's going to go way, way down. And so what we need here, and again, this is speculative, but I think we need to rely more on observational skills. We need to look and understand what are the cues that could tell us that a patient is in this type of state, and we need to take a little bit more of a role in recognizing that a patient might not have the words in that moment to describe fully what's going on with them. And I think we could take cues from assessment strategies that are anchored to pediatrics or older folks with cognitive loss or dementia in terms of how to approach that. And again, what we're doing with that approach is trying to look for indicators that a patient is overwhelmed, incapacitated, dissociated as a result of their pain. Similarly, when we think about, again, early ideas on how to approach management of different forms of suffering, I think a tailored approach is also a good strategy. And again, completely speculative at this point. But thinking about narrative self-disruption, I think treatments that specifically focus on things like values, meaning, re-engagement, and life roles might be helpful. So things like maybe acceptance commitment-based therapy that try to get at those themes. Maybe narrative self-suffering could be a tool that could help direct people to treatments like that and also to evaluate their efficacy. Think about minimal self-disruption. I think here, first off, I think what's really important to recognize is what treatments won't work. So thinking about, a lot of our gold standard treatments in chronic pain management, they require a lot of self-reflection. They require a lot of executive function. They require a lot of self-regulation, that if somebody is having a lot of these overwhelmed experiences with pain flares, they're just not going to be able to engage in a lot of self-management strategies. Initially, they're not going to be able to engage in a lot of activity-based interventions or even probably cognitive interventions that require self-reflection. And so being able to meet the patient where they're at and trying to find ways of relief from that overwhelming bodily pain is probably an important strategy. So again, this is really just kind of the start of this literature and research for us. The next steps that we're looking at is kind of trying to co-create with groups of people who are living with pain a definition of pain-related suffering. That we can kind of all get behind from a research point of view, but then also from a lived experience point of view as well. We're also trying to better understand the relationship between self-disruption we've talked about and then also established psychological constructs. I think some of the questions that I'm really interested in is like, how does self-disruption contribute to things like despair? How does selfhood maybe act as a buffer related to psychological distress? And again, Gilletta had this great reference this morning to the idea of making space for pain. And what I love about that is, one idea in terms of how maybe we could mitigate suffering is to make our self outside of pain bigger and richer. And thinking about maybe as clinicians how we maybe could facilitate some of those ideas. And then the next idea is trying to tailor our management strategies to different forms of suffering. So just really to wrap up, so when we think about these big problems with pain, some things that maybe historically haven't been readily accessible to us as clinicians, I think I really am interested in how this concept of pain-related suffering can help us get at that, help us get at more of the person in a full way in terms of what pain has done to them in their life. And I think it's important to recognize that it's two different modes of suffering, so pain, narrative self-disruption, minimal self-disruption, and recognizing that these things are interrelated, and they kind of have a reciprocal wave-like relationship to each other. And then thinking about management, potentially think about tailored strategies to when we can recognize these different forms of suffering, how we might be able to direct care towards that. That's it. Thank you so much.
Thank you so much. All right. Oh, we have a question already. You don't have to say anything.
Thank you so much. I'm sorry I came in a little late. Similar to what I mentioned in the earlier talk today, you talk about suffering, you talk about self. These are things that have been talked about in the sutras for millennia, right? The idea of suffering coming from our attachments to the sense of identity, to the cravings, to the aversions, to the delusions, that we don't like what's real, what is right in front of us. I believe that accounts for both of what you're describing, the sense of the narrative self as well as the minimal self. And for that matter, that's, again, the whole practice of cultivating this understanding of the self is through connecting to that minimal self and seeing how that relates to the larger context, that there is no self without a social context, without connection, without language. So I feel like it's really important to tie these things to these older traditions that have been talking about this for all this time anyways.
I think that's a great point, and I really agree with you. So there was a commentary that was published on the paper that I referenced, and you might want to check it out. And we responded to that. And part of the commentary, I think, was making the point that you're making. And so we have a letter to the Journal of Pain that I could send you if you send me an email, or you could find it. But it tries to situate these ideas in a really preliminary way in relation to some of those kind of Eastern and Buddhist traditions. And I think the first thing I want to say is I think there's many paths to the alleviation of suffering. And I think for many individuals, a big part of living with pain is finding those paths and what works for them. And I think that a lot of folks I can imagine could find Buddhist traditions be helpful in kind of gravitating towards that. The other thing, sometimes we use, and I think, sometimes we use this idea of suffering equals pain times resistance. And we kind of fall into this idea of hey, all we have to do is just not resist the pain. And I think in many ways, yes, that makes sense. But I think what it maybe undermines, particularly if a clinician is telling a patient that, I think what it loses is just how much loss there is in that. So to not resist pain means we're losing all those aspects of ourself that are dear to us or that are important to us. And so I think the importance there is not to trivialize that loss and recognizing that there's still going to be a process around that. And I think, again, Gilletta did such a good job talking about that, and Cass did as well, talking about that journey of coming to terms with pain. So I think that's important. The other thing is that moment-to-moment experience. So we think about some of the Buddhist practices, and I'm not Buddhist, and I don't know all the practices, but we think about mindful meditation as a part of that practice. When we think about what it takes to sit quietly, and then we think about the minimal self-experience, we need to recognize that there's a lot of folks that will not be able to cultivate that state of consciousness because of their pain. And so it's we can still let go of our identity, we can still let go of our past and our future, but there's this incredible hellish disruption that can happen in that moment-to-moment experience that could make a meditative experience really challenging, maybe risky for some individuals as well. So I think that it's an important pathway, and I think that it's an important pathway that could work for many people. But I don't know if it's always helpful to think about it as the only pathway for me.
Sorry, but I do need to, I want me to use the mic, but I do need to respond to that real quick. Thank you. So, yeah, yes, mindfulness meditation is a part of the practice, but the Four Noble Truths refer to an eightfold path, right? Mm-hmm. You can't do just sitting meditation and expect to achieve everything on that path, right? That is a lifelong ambition. Yes, it's difficult to do the meditation when you're experiencing pain, and that is part of the practice, to experience the pain, right? That is the practice. Mm-hmm. And the attachments we're talking about isn't, the acceptance of the pain isn't the point. The awareness comes from the awareness of your own attachments, your own aversions, your own delusions. That's where the growth comes. And I could go on for much too long about this, but I really think it's important to really consult with people who have this knowledge and expertise and lived experience in that practice. And the goal isn't to, rise up above all of that, but to connect with that experience and that awareness that we belong to each other. What Mosley said about love and be loved being the answer, that's the Buddhist concept, really. So it goes much further than sit and accept the pain. It goes much deeper.
That's great, and there's nothing that you're saying that I disagree with. I think it's just recognizing that not every patient will want to take that path, and it's trying to work with the patient in front of us. Yeah, thanks.
Thank you for your talk today. I've noticed, I'm a massage therapist and also a yoga therapist, and I've noticed that when I'm working with people with pain, their breath pattern is very interrupted.
Mm-hmm.
And so using not so much like a particular technique of like a breath practice or pranayama in yoga is just to bring them to a slow, deep belly breath.
Yeah.
And I read a study recently where there were two different groups of people, and they were measuring effects of breath on pain and how could it modulate pain. And with one group, they were hooked up to biofeedback, and they were shown an ideal breath curve on the screen, and they had to match their breath to that curve. Are you familiar with the study?
Nope.
And then they had a second group of people who, you're familiar with it? They were instructed in the same technique in slow, deep breathing, but they weren't hooked up to anything. They weren't looking at a monitor. They were just looking at a blank space on the wall. And there was a group that the breath decreased their pain, but it wasn't the group that you might think, like the one who were given and follow these instructions, like that. For them, their pain didn't change, or it actually increased. And it was the people who were instructed more to feel within themselves and breathe that they recognized the decrease in pain. So I thought that was really interesting. There was an extra layer of cognitive comparison that influenced in that study. And I also think that, I was wondering, when you say minimal, the minimal self,
Yep.
do you mean by that like a smaller in terms of minimal, or more of like a foundational baseline sort of
Yeah,
consciousness?
foundational base would be a much better way of capturing that. So thinking about where consciousness starts, and then a lot of us have this identity that is layered on top of that, but all of us still have that minimal self. And I think the breath work you're talking about, meditation practices, those are great ways to connect with that minimal self experience, and maybe to help with some of the regulation that can be associated with disruption to the minimal self. So thinking about your body, situating yourself in the body, and trying to cope and address and with a moment-to-moment discomfort. I think these are speculative, but I think those are great strategies that we should be exploring.
Yeah, I'll just say too, I don't really talk with my clients about, I don't use the word Buddhist or yoga with it. I found I like resonating with me personally with people who think they can't do that, or they're not familiar with it, because they're almost easier to teach in a way, because because I had an experience myself where I did a lot of pranayama for years, and it really wound me up.
Yeah.
And I needed to unlearn a lot to kind of just find a breath that was more like the ocean that I could kind of ground. And so I just thought I would add that too.
Yeah, thank you.
Yeah.
And I think that's really important work. We're good? No, we got...
Okay, this one comes from Michelle Bellamore from online, and she asked, do you have any tips for individuals who do disassociate to cope with their pain? Some of my people disassociate with their bodies to escape their pain, and they have a hard time embodying their physical beings in a way that feels safe for them, especially as persons whose pain is not validated.
Yeah. So I think, I am really hesitant to give specific tips, because I think it's just right now outside of my expertise. We had individuals that we interviewed that was interesting, because they would describe, these dissociated states that would have happened years ago. And then then they would bring you into the present and be like, oh, but I learned how to cope with that. And they would kind of rattle off a number of different things. And I think some of the strategies that worked for those individuals were things that are also working. Dissociative experiences are associated with other psychiatric conditions. And maybe we can learn from some of that literature out there in terms of how to address that. Learning about PTSD, for instance, and treatments related to the moment experiences of flashbacks. I think there's a lot of richness there that what we can look at that literature and bring it to clinical management. I haven't done that yet, and I don't want to speak beyond my level of expertise. But I think that's hopefully where we're going, is to have a set of tools that we can be using for these patients to help them. Hi, yeah. I'll come back down.
Thanks so much for the talk. I found it. Testing.
Yeah.
Thanks so much for the talk. I found it really cognitively stimulating and emotionally evocative. I like the framing. I like the granularity and really giving language to kind of these cognitive distinctions. I think similar to the last comment, I was just really struck all the way through that you never use the word trauma, but you're talking about trauma. And I guess I'm curious, do you see similarity and overlap or synonymity, or where would you put the Venn diagrams between what people experience when they talk about trauma and what you're talking about when you talk about suffering?
I think I think that's a great, so thank you for those comments, and I think it's a really great point. I think what was so eye-opening to me is that it gave me a lens just to see, I use the word just in quotation marks there, but a pain experience and how that could be potentially a form of trauma itself. And you think about, the documentations of torture and how obviously traumatizing that would be for most individuals that go through that. But yet you have these individuals that are just stuck in their body and having those experiences. And so, it made me think about fear and how we think about fear in the literature. And I think that there's just like a trivialness to how we think about fear in the psychology of pain literature that doesn't capture the potential for trauma just associated with pain. So I guess what I'm trying to say is, like, potentially I could see a direct overlap where we don't have to have, we could have a score of 0 on our ACE scale, adverse childhood experiences, but still have important trauma just living with pain. So I think I guess I would say I fully agree with you, and I think it's maybe even extending how we think about trauma as something that has to happen external from us, just something that could be experiencing inside of us.
Thanks very much.
Yeah.
So awesome work, Peter. Sorry, I'm loud. I'm a French Canadian. Awesome work. I'm buzzing right now. What you shared around so I've studied trauma and pain for like 15 years. And I remember, Laura Heathcote, I don't know if she's in the room, but I remember one point she was like, maybe pain is the trauma.
Yeah.
And Keith Meldrum, who's just like amazing, as is Virginia, I'm with you, like it's just totally changed the work. We wrote together this paper around how living a life, and we were intentional around living a life with pain can in and of itself be a catalyst for toxic stress. Why?
Yeah.
Because it's robbing of connection. Now, we had thought of that in terms of, I'm buzzing, you guys, stigma and marginalization and diagnostic uncertainty and all the stuff we talked about yesterday. But as I'm listening to you, I'm like, the trauma is in the disconnection from self. It just like all came together around that is the trauma. And, it's so interesting. We did that too. What you're hearing in these narratives, we hear from 12-year-olds.
Yeah. Yeah.
I just showed Virginia being washed away from pain. And the beauty in hearing your story in someone else and the validation in it and the narrative possibility
Yeah.
that story can change.
Yeah.
And you asked about the worst pain experience. Well, anyone knows, like peak end effects. We remember the worst or the end.
Yeah.
If we're alive, it isn't over.
Well, it was.
So you're tapping into that. It is, dude, guys, there's so much here. And I'd never seen it, and you brought it to life, and I'm buzzing. Amazing
you.
work, like, and with so much possibility.
Yeah.
For healing in this. Arthur Frank, narrative possibilities. We need stories.
We should talk.
Grief.
Thank you, Mel. And the thing, thank you. That's super kind, and that really means a lot to me. And what I'll just mention is like the vividness of recall here. Like we were talking about experiences that were sometimes decades old. And the way that folks could unpack, like, just with so much vividness, and that's where that safety came in, because for a lot of these folks, they were just reliving those experiences, and so we need to be responsible in how we get at that. But it was just kind of like, wow, yeah.
Amazing. And just so everyone know, I saw your hands, but it's 2:00, and I want to make sure everyone has the time.
I'll stick around.
To take whatever breaks they need to take. And there's always time to come and chat. So please come, chat, stretch your legs, and we will start the next talk at 2:15.
Thank you, folks.